Hi everyone, it's Hunter Hicks. Today we're going to look at medications for heart failure, hypertension, and we're going to cover calcium channel blockers. If you haven't seen my other videos, we do talk about a lot of other medications for these diseases like ACE, ARBs, and diuretics. Go check them out if you'd like. Okay, so calcium channel blockers. In general, what we're doing is obviously blocking the calcium. Now, calcium has different effects both in the vessels and the heart. In the vessels, we know that as we increase those calcium channel, we increase into the channels themselves, we get vasoconstriction. Therefore, by blocking that, we can help out patients that have hypertension. And in the heart, we know it helps with contraction, SA node conduction, or really the pacemaker of the heart, so the overall heart rate, and then AV nodal conduction. So when we look at this, we have dihydropyridines and our non-dihydropyridines. Dihydropyridines work primarily only on the vessels. For that reason, they're going to be good for hypertension, but they might not be helpful if we're trying to treat a heart condition, such as a dysrhythmia. It's also good because their side effects might not be the negative side effects we see with non-dihydropyridines, like maybe decreased heart rate, decreased force of contraction, making these not the best medications for heart failure. So as you can see, dihydropyridines and non-dihydropyridines, their uses are going to be different, and then their overall side effects are going to be different. One working more on the vessel, one working on the vessel and the heart. So dihydropyridines like nifedipine, Procardia, we know is a very common medication, or nicardipine is another one as well. So they work on the calcium channels of the vessels. One of the biggest uses we're going to see is hypertension. A lot of times, calcium channel blockers can sometimes be first line. They can be combined with an ACE or an ARB or a diuretic or something like that for hypertension. Adverse reactions, as we know, it's going to be working on the vessels so we can get hypotension. And the good thing is we see less of those negative cardiac effects like decreased AV nodal conduction, decreased SA node conduction, and decreased force of contractility, which overall can put our patients at risk for things that we don't see with these dihydropyridines. Non-dihydropyridines like verapamil or diltiazem or cardizem, those guys can be used for hypertension as well, but more commonly we see them used for cardiac dysrhythmias because they're going to block the calcium channels in the heart, therefore put them better use there. But because they block calcium channels in the heart as well, they're at risk for things like hypotension, which we can see with their dihydropyridines because they are working on the vessels, but the heart stuff we see is like maybe bradycardia, maybe decreased force of contraction, decreased AV nodal conduction, which if your patient overall is a pretty healthy person and their heart is healthy, we don't really see these being super severe, but if they have a really bad risk, like a decreased EF and stuff like that with bad heart failure and stuff, this might put them at higher risk for negative cardiac effects. We can see some degree of constipation, especially with verapamil, because it works on the calcium channel and the smooth muscles of the GI tract, but he's really unique. We can see some constipation with the others, but verapamil is one of the bigger ones. Now, in general, when we look at hypertension is a pretty complex disease process. Now, we both have primary and secondary. Primary meaning we don't have something that we can literally pinpoint and say, that's why you have high blood pressure. What I mean by that is secondary would be like pheochromocytoma, right? Or thyroid disease, right? Something that we directly know is causing it. And if I fix that right now, your blood pressure will be normal. Majority of patients, we just are like, it's a mixture of things, right? We have increased inflammatory reactors going on. We have a lot of sympathetic tone maybe causing it. We know that all these things work together. We know that the RAS system is turned on, right? So in general, we get the sympathetic receptors like catecholamines getting released. They cause vasoconstriction, which may cause damage, and then we get more inflammatory reactors. They come in, they cause damage. We get the RAS system, which we know angiotensin II and aldosterone cause all these pathological changes in both the heart and the vessels. So it's really a big pathological thing. We're not going to dive into it today, but I want you to know that majority of patients have primary hypertension. We just know that overall there's a lot going on in the body that's going to cause high blood pressure, but there's not one certain disease that I can say that's why your blood pressure is high. If I fix that today, you will be good to go. So in general, when we look at this, we want to take their blood pressure on both different arms, 5 minutes apart, try and make sure they've had 30 minutes of rest, no nicotine, nothing like that to increase their CNS. feet flat on the floor, legs uncrossed. Sometimes providers find it helpful for patients to take it at home as well because it decreases white coat syndrome. But in general, we know that when we look at this, 130 to 139 is stage 1 hypertension, and 80 to 89 is stage 1 as well on the diastolic, and then above 140 over 90 is stage 2. Our goal in treatment is less than 130 and less than 80. So initial therapy without any compelling indications, such as like they have hypertension that's causing heart failure, they have hypertension that causes coronary artery disease, or they have diabetes, which puts them more at risk for the renal component of this as well. We usually can start them on a thiazide diuretic, and then an ACE and ARB or calcium channel blocker, all good first-line therapy. Now, the good thing is hypertension, the thiazide will work by decreasing the fluid content, but like I said, we're usually going to see this combined with an ACE or an ARB. We know ACEs are one of our first go-to because we know those guys decrease mortality and hypertension, where ARBs aren't the best at that. And then a calcium channel blocker is always an option as well. Now, when we're adding medications on, we always want to try and add from a different class because all these medications outside of ACEs and ARBs work relatively differently in how they're going to treat hypertension. So we know that combining them will work at different sites of the hypertension and hopefully help bring down the overall medication or high blood pressure. The other thing is combining medications might help with the side effects. Let's give a good example. If I give someone Catepril or lisinopril, which is an ACE, we know it blocks aldosterone. Aldosterone increases sodium in water, kicks out potassium. That's great. That helps decrease blood pressure. But by increasing the potassium content, I put my patient at risk for hyperkalemia. But if I give a thiazide diuretic, which will help diurese more potassium, we know that works in the distal tubule, well, then those kind of balance each other out, right? So again, sometimes they help by working on different sites for high blood pressure, but they can also offset each other for their bad side effects. It's the same thing where you got to be careful if you're giving an ACE and an ARB, or you're giving medications that do the same thing, that have the same side effects, you might just combine those risks, so be careful. Obviously, dose is always low and slow. Patients that have high blood pressure, especially if it's really, really high, if you give them a whopping dose, you're going to reset that baroreceptor way too quick, and you run the risk for that first dose hypotension and a lot of other things. In general, these guys have chronically been living with hypertension. So yes, we want to reduce their risk, but we don't have to do it today, right? We want to do it over time and try and help prevent those risks long term. Even when patients come in for a hypertensive crisis in the ICU or ER or stuff like that, we don't just smoke them from 200 down to like 90. Well, that would be very bad, and they probably not do well with that. So we try and decrease it like 10 to 15% the first hour, right? We've established they have high blood pressure, but we don't need to just bring it down super fast. There's little things in medicine that we do that very, very fast, right? So in general, low and slow. And the good thing is if we do this slowly, we actually give time for those baroreceptors to reset. So they might reset nice and easy so we see less side effects, and then they might reset over time to that new established blood pressure. Step-down therapy, so really after a year of these patients being on medication, we can look at maybe decreasing dosing, coming off some of the medications, as we know maybe that baroreceptor is reset. But in general, we want to make sure that they never, ever, ever stop their lifestyle modifications like the DASH diet, low salt intake, making sure they're exercising and stuff like that. Now, heart failure is a little bit different. So we know that heart failure really is divided into two. We have heart failure without, where the LV systolic function, and without. So basically, they have heart failure where their LV is so bad that we have really bad cardiac outputs, so their blood pressure is usually pretty crappy, those chronic sick guys. Or they have heart failure, but in general, we still have pretty preserved LV function, so we'll have good blood pressure. In general, what heart failure is, and we're not going to go super big into patho here, but heart failure is where the heart can't meet up with the metabolic demands of the body. Meaning, if you go walking and you're trying to push oxygen, right? You're trying to deliver oxygen to the tissue of the legs, of the arms, or wherever, because those muscles are working, they're using more oxygen. Your heart's like, I simply can't keep up with it. So that's why one of the most common things we see is just this shortness of breath. Shortness of breath when they're doing stuff, or eventually shortness of breath just in general, because the heart, or at rest, because the heart is so sick. It literally can't keep up with basic metabolic demands of the body. So in general, we just see decreased tissue perfusion. That's why we see shortness of breath, fatigue, exercise intolerance. All that is from decreased perfusion. Now, in general, we'll start to see edema because as the fluid fills up in that heart, it's going to backflow into the lungs and then eventually backflow into the periphery, right? We know the most common thing that causes right-sided heart failure is left-sided heart failure. Now, here's what happens in general. This is a total big cycle that's going on. When the heart's failing, the body's like, I got to help you out. You're not getting oxygen to where I need you to get it, so why don't I help you out here? So remodeling is one of the things we see here. So the cardiac ventricles actually dilate. Well, they dilate for a couple of reasons. One, increased venous pressure. So when they have increased venous pressure, we're going to get more of a preload because the body's like, dude, you're not giving me enough fluid out. So I'm going to give you more ammo or preload you more so you can push more out. So overall, they're like, okay, now I'm only taking this much fluid. I'll take this much fluid. Well, we stretch them a little bit, which is good. So we get increased output at first. The other thing is because of decreased output, we're pushing out less, we get more return. So overall, when we look at our end systolic time, right, we know at the end of systole, those ventricles should be totally empty. But we start seeing heart failure, they're not totally empty. Because one, we're filling them more, and two, we're not getting it all out, so some of that's coming back. Well, overall, like I said, when we increase preload, we stretch it out. We stretch out that rubber band a little bit, which is good. We get increased cardiac output at first. But overall, as we stretch and we stretch and we stretch, they can't really retract as well as they wanted to. Like the rubber band's here and it's like, oh, that's easy. But we stretch. So like I can't even come back to push out that fluid. And that's that Frank Starling law. Other things we see is increased contractility, which is great. So the body's like, hey, I need you to contract harder to push out more fluid. Again, that works at first, but now the heart's like, hey, I'm working hard. So stop giving oxygen to everyone else. I need oxygen myself through the coronary arteries, which increases his oxygen demand, which can put him at risk for myocardial infarction and stuff like that. Hypertrophy, we can totally see. So hypertrophy is just the muscle's going to get larger, right? Thicken that muscle up, which in theory makes sense at first because we're going to push. If we have more muscle, we're going to push more out, which eventually helps. But as it gets thicker and larger, that just doesn't help at all. We get more hypertrophy, which we can't even fill as well now in the ventricles, and they're just too big to even do anything. And that comes from some of those pathological changes we saw from the RAS system, but also from the catecholamine. We can also see the secondary to hypertension, right? We know hypertension is a big cause of heart failure because the body compensates from the decreased cardiac output by increasing our arterial tone. So it's like, well, you're not giving me enough fluid, but I'm just going to make it get there faster by trying to constrict my blood vessels. But then the heart's like, now I got to push against this really high pressure all the time. So as you can see, the heart tries to get thicker, more fibrosis, more of this thickening of the heart, and hypertrophy of the heart, and eventually that fails on itself. Last but not least, water retention. Well, because we're not getting to where we want to get, the RAS is stimulated. We know that renin gets released from those from the nephron itself when we see like decreased salt intake or decreased perfusion, which can be from cardiac output or hypovolemia. This portion, cardiac output, decreased, the renin gets released, which then turns on angiotensinogen, and then we get angio 1, angio 2, blah, blah, blah. We've talked about that in other videos. So that's good at first. Well, we get more preload, more fluid into the heart, but eventually we start to see where the heart can't keep up, and that's a risk for our edema. So why I explain all this, you guys, is this compensation is good at first, and it's what the body does, but it actually hurts us long term. The other reason I tell you guys this is that's why you can see a lot of the medications we give block all these things. Like increased contractility and all this might come from sympathetic nervous system, so we give medications to block that, like beta blockers or alpha blockers, right? Or the RAS system, we know it causes remodeling, causes this fluid retention, causes this increased preload, so we give ACEs and ARBs and aldosterone blockers to block that. Well, we know we have too much fluid on board. Well, the fluid on board causes too much preload in the heart, which causes dilation, which causes edema. Well, then let's give diuretics. So if you understand all those compensation things, you understand why we can block all those. Now, classification severity, there's really two depending on what you use. We have the New York Heart Association, or the AHA, and the American College of Cardiology have both combined and talked about this. So class 1 for the NYHA is no limitation on physical activity, all the way down from slight to marked. And then once we get all the way down to class 4, we have symptoms that occur at rest. That's where the heart just can't keep up with basic metabolic demand of the body. AHA and ACC is a little bit different. They're looking more at the structural component of it and symptoms. So stage A, they're at risk, without structural heart disease. So these are just patients maybe that have an MI or had an MI in the past, have hypertension, have diabetes, all these things. They have cardiomegaly, things that, or sorry, not cardiomegaly, but they have things that put them at risk for heart failure. So it's kind of these guys we're watching. They don't really have the structural stuff like cardiomegaly is what I meant to say. They don't have the structural components like hypertrophy or dilation, but they're definitely at risk and they have no symptoms yet. Stage B, now we see like they have the structural heart disease, but they're still asymptomatic. So we want to make sure we're on top of those guys before they get asymptomatic. Stage C, they have the structural heart disease, and now they've had symptoms. They're like, yeah, well, I go play tennis and I get short of breath. Or I go up the stairs and I get short of breath. Or they're currently telling you, or they're like, and I had that, now I don't have it as much. Or they currently tell you, like, yeah, I noticed walking from the parking lot, I got short of breath on the way in here. I want to you guys keep in mind, keep your differential high. Obviously, shortness of breath can be a ton of other things. It doesn't have to be heart failure. It's just that's one of the most common things you see here. Stage D is the sicker patients. These are the guys in the ICU, guys in the hospital, where we know they have refractory heart failure and they need mechanical assist device, so like LVADs, RVADs, balloon pumps, Impellas, ECMO, stuff like that. Their heart is so sick. These are guys that are probably on the transplant list, maybe, and stuff like that. Now, when we look at treatment, we kind of talked about this. We're trying to treat all these compensations. So diuretics are good for fluid removal, and they really just help more with symptoms. Now, they can prolong survival, possibly like potassium-sparing diuretics, but we know that really why we're giving these overall is because it makes them feel better. We get the edema off. We get the edema off the lungs for their shortness of breath and off the dependent edema and stuff like that. And by decreasing the amount of fluid on the body, the heart doesn't have to push out as much. So we know thiazide versus loop. Thiazides will not work if your GFR is relatively below 15 or 20. So these are patients with really end-stage or sicker heart failure patients. So they might need more of a Lasix. As we know, Lasix can work either way, right? So if your cardiac output's bad, your kidneys aren't working, GFR is low, you might need a higher, like a loop diuretic. Spironolactone or potassium sparing, block the aldosterone, which we know helps out with those pathological changes. Beta blockers, we talked about these. Beta blockers are interesting. You think giving a beta blocker might actually put them in worsening heart failure, which can be a side effect, but relatively we found if we dose them right, they can be safer and help out these patients because they block all that sympathetic catecholamine effect that causes the hypertension and the increased contractility and stuff like that. ACE inhibitors are great. We know, again, they're prolonging survival and hypertension and even CHF because they're going to decrease a lot of those pathologic changes. So lowering angiotensin 2 leads to both arterial and venous dilation. So what we see with arterial is we're getting better flow to the kidneys. When we get better flow to the kidneys, they'll actually diurese better, right? They're not going to hold on to fluids like they would. They're going to diurese more, which will get more fluid off. And it reduces afterload, which we know we're pushing against that afterload. Remember, angiotensin 2 is a potent vasoconstrictor. So we block him, we get decreased hypertension, which we know is why we use ACEs there, but it decreases the overall workload the heart needs to get on. Venous is going to reduce the pressure, which we know increased venous pressure, more hydrostatic pressure, pushing out pressure causes edema, but also the preload, which causes that cardiac dilation. So that helps there. By blocking aldosterone, we get less water and sodium. Again, that's just the idea of less water on the body, and we reduce cardiac modeling. As we know, both angiotensin 2 and aldosterone does those pathologic changes. ARBs kind of do the same thing, but again, we have kind of seen research-wise, ARBs are just kind of secondary to ACEs as far as mortality and stuff like that. We do have one medication you probably heard a lot called Entresto, which is kind of a mixture of an ACE and an ARB usually, and it releases some ANP, BNP, which are those natural diuretics that we see in those stretch receptors of our ventricles. So this medication you can see commonly here as well. One other medication, even though it's kind of an older medication, is digoxin. Digoxin used to be first line, now it's second line for heart failure. Digoxin is going to be a medication that's overall supposed to kind of really help with contraction of the heart, really make it more contracting kind of better, increase our cardiac output. So if we increase our cardiac output, increase our contractility, overall we're going to perfuse the kidneys better, so that should shut off the RAS system, which should shut off all the fluid we're containing, which should shut off the hypertension we're seeing, and yada, yada, yada. So overall, if we perfuse everyone better, they'll start to back off and help us out. how it works, you guys, is we're not going to get super into it, but when we look at the sodium, potassium ATP pump, after a contraction happens, we push out sodium, which then pushes out calcium. If we block that, sodium stays in, so calcium will stay in with him, and we get better contractility of the heart overall because we're keeping more calcium inside the cardiac cells. The only thing with digoxin is potassium will compete with digoxin at its ATP pump. So that's why you need to be very careful with your potassium levels with digoxin. Meaning, if your potassium's high, he's going to win the fight. He's always going to get to that pump before digoxin does. So your digoxin just won't work as well. If your potassium's low, digoxin will be able to bind way better, way easier. Therefore, you can get toxic digoxin levels. Which brings us to our next point. Toxic digoxin levels are pretty easy to get because there's such a narrow therapeutic index. Remember, the therapeutic index looks at how much of the medication do we need for it to actually work, and then how much do we need it to be lethal. If the amount for it to work is 5 and the lethal amount's 80, well, that's a huge therapeutic index. You need to really take a lot of it for it to be lethal. Whereas a low or narrow therapeutic index, I only need like 5 for it to work, and then I need like 6 for it to be lethal. So as you can see, digoxin, its levels are 0.5 to 0.8, super small. You only need a little bit more digoxin in the body to cause some serious effects. So some of the things we'll see first are these non-cardiac effects. So they might see yellow tinge, halo around lights, nausea is very common. And then eventually they will give us dysrhythmias, which is funny because digoxin can be used for dysrhythmias, but it causes dysrhythmias, as any antidysrhythmic med has proven to us. Any medication that can treat dysrhythmias can also cause them. So for digoxin, be very careful with your potassium levels. So if you're giving medications with digoxin for heart failure, like, I don't know, a diuretic that's going to push all your potassium outside of the body, be very careful, because if that potassium starts to get lower and lower, your digoxin is going to get better and better and lead to risk of overdose. We know we have medications like Digifab, Digibind to help with this digoxin overdose. Overall, that's all I have, you guys. Quick, down and dirty. If you have any questions, please leave me a comment. If you like this, go ahead and give me a like, and I'll see you next time.